Yes. That's
Good.
fine,
Okay.
Andrew.
So, okay, good. Thank you. Welcome everybody. My name's Andrew Hart, and I'm a Uro-Oncology cancer nurse specialist at Worthing Hospital. I have also worked at the County Hospital in Brighton before, as a urology research nurse. And I've been doing cancer nursing in urology for about 8 or 9 years now. So I'm with the group of nurses that cover sort of the Worthing area, but we also, obviously our trust also covers Chichester. So I'm going to put up a few statistics about COVID to start with, but it's mostly about Western Sussex because obviously that's the area that I cover. But I did sort of poll my colleagues in Brighton and in Eastbourne about how they sort of managed during the COVID crisis as well. So the first few slides are just about sort of how we did across the Worthing patch during the COVID crisis and how that has impacted on urology services or not. So in Worthing and Chichester, we actually had and still have relatively low numbers of severe COVID patients during who required any sort of prolonged hospitalisation. I don't know the exact mortality figures, but sort of compared with national data sets, I think across Western Sussex, they've been generally fairly low. And indeed, cancer staff in Western Sussex were generally redeployed to other areas to cover COVID patients during the height of the pandemic. And most of us managed to continue working in our own departments for the most part. Some people worked from home, and I did for a while during sort of April, May. I worked for about 8 or 9 weeks at home. And we managed to switch almost all of our clinics from face-to-face clinics to telephone clinics. So obviously we were able to contact people at home and from our own homes. And that's continued post sort of lockdown to some degree. And it's quite interesting really, because it's kind of changing the way that we're working, in as much as we are able to do telephone clinics more. And that might end up being a long-term change, that we end up doing more telephone clinics rather than face-to-face clinics for certain things, particularly for people that are stable. So in terms of prostate cancer support and follow-up, we're looking at people maybe that are on things like active surveillance, which I'll go on to talk about in a little while, that we could do that over the telephone rather than face-to-face clinics. Obviously during COVID there was a high degree of stress and uncertainty, and there is difficulty in continuing to work and sort of balance our sort of home and social lives, but I think that goes for everybody for, that's been impacted during the most of 2020. There was definitely a significant reduction in the number of new referrals, and there still is. It's starting to pick up back towards normal now. In fact, we've had to put on extra clinics lately because there's been a bit of a glut of referrals. So I think we're kind of catching up a bit, but there was certainly a very significant reduced number of new referrals during the COVID period. And obviously that's not just in prostate cancer and in urology in general, but across all the cancer services and across hospitals and all services as a whole. That does mean that there's a potential that we're picking up cancers later as well, which is a possibility. And we have, in fact, we haven't sort of audited it yet, but there's a possibility that we may have picked up a few cancers at a later stage than we would have normally, simply because the referrals weren't done during the height of COVID. Services that were reduced or stopped are now restarted. So most services are back to something approaching normal. So that's our biopsy services, radiotherapy, cystoscopies, chemotherapy, scans, that sort of thing. Some treatment schedules were altered, which is an interesting one. So, for example, men with metastatic prostate cancer, so prostate cancer that's spread, we would normally give chemotherapy as well as hormone therapy, and we would give chemotherapy up front for newly diagnosed men with disease that had spread. Because we were very circumspect about giving chemotherapy during COVID because of the risk of lowering immunity, the NICE have approved the use of enzalutamide rather than chemotherapy. So now we've been giving the oral hormone therapy drug enzalutamide up front for men with newly diagnosed metastatic disease instead of chemotherapy, and we weren't doing that before. So that's an interesting change. And so far, the patients that have started on hormone therapy and enzalutamide have responded very, very well. All hospitals across East and West Sussex responded really well to the COVID crisis in terms of how we had to change wards and secure areas and providing ventilators and redeploying staff and PPE and all that sort of thing. It actually went quite well. But as I mentioned, there are some ways of working that may change, and may change in a very positive way, doing things like telephone clinics or virtual consultations, usually using telemed, things like Zoom or Teams, staff working from home rather than have to come in if they're more sort of office-based staff. And we're certainly doing a lot more of that for people that have more sort of office-based roles than clinical roles. And more virtual staff meetings, for example, our MDT meetings, our multidisciplinary team meetings, which we have once a week. Normally there's a load of us all gathered in a big room, and it's like herding cats half the time because you wait ages for all the consultants to arrive. But when we were doing it virtually, then everybody could dial in from wherever they were sitting at the time, and we started a lot of the meetings on time, which was quite good at doing that. So as awful and terrible as COVID has been, and how it's impacted on the health service, there are some potential positives that have come out of it in the way that we work. That's all I'm going to say about the COVID situation for now. I'm going to move on to talking about surveillance, because I was asked to just do a bit on prostate surveillance. So when we're doing surveillance for men with prostate cancer, it kind of generally falls into two categories, and this can be a bit confusing sometimes about what sort of surveillance we're talking about. And there are generally two types of surveillance. One's called active surveillance, and the other one's watchful waiting. And there is a distinction between the two. So active surveillance is normally generally speaking, aimed at younger men, or men under 75 certainly, that have low-grade localized prostate cancer, who are eligible for radical or potentially curative treatments, so such as prostatectomy or radical radiotherapy. So this is what we sort of call deferred treatment. So this is for men that can go on and have radical curative therapy, but at the moment have low-grade disease which does not require immediate treatment. The other type of surveillance is what we call watchful waiting, and that tends to be what we do for the older age group. And again, they're men with a localized prostate cancer, but there may be, because of age or because of lack of physical fitness, they're not eligible for radical treatment. But they may have something like hormonal therapy, which aims to control the disease rather than cure it. So that's kind of the distinction, and we keep a closer eye on active surveillance patients than we do the watchful waitings in terms of things like PSA monitoring or imaging. So active surveillance is deferred radical treatment. So it's regular scheduled surveillance. So PSA checks initially done every 3 months, usually for the first year, and then if everything's stable, we drop it down to 6 monthly PSA checks. And obviously we're checking for things like PSA rise, the rate at which it's rising, if it's rising, the PSA doubling time. These are all the sort of measures and metrics as to what would trigger us doing further investigations or triggering active treatment. We do MRI scans regularly for active surveillance patients, usually at around 18 to 24 months. So we do those every sort of 18 months to 2 years regularly. And we might repeat biopsies. Certainly if the diagnosis, if you've just had a truss biopsy, if you've just had a biopsy under local anesthetic through the back passage, that have taken sort of 10 to 12 samples, then what we tend to do for the active surveillance patients is do template biopsies at 6 months. And template biopsies are done under a general anesthetic, and we take much more biopsy samples. We take 20, 30, 40, sometimes more. And that's just to absolutely make sure that there's no higher grade disease than what we sampled on the truss biopsy. And obviously we monitor for symptoms, of course, and should anybody have any symptoms of concern, that would again trigger us doing, bringing forward MRI scans and that sort of thing. So if anybody does progress on active surveillance, if, say, for example, the next MRI scan looks more suspicious, or on repeat template biopsies, they've upgraded from Gleason 6 to Gleason 7 disease, then obviously we can offer them radical curative treatment options. So the aim of surveillance is really not to overtreat patients who do not require radical treatment at the time, but who may possibly require it in the future. What we don't want to do is treat everybody with radical treatment and give people prostatectomies and radiotherapy and stuff when they don't really need it. Watchful waiting is slightly different in that it's not deferred radical treatment. It's in a sense it's deferred hormonal therapy. So we do PSA monitoring only of every 3 to 6 months, and again we monitor for symptoms. And we would normally start hormonal therapy if there's a significant rise in the PSA. Usually that's around a level of about 30, but that's not a that's a fairly arbitrary cutoff point. We do start hormones if the PSA is goes up, not necessarily to 30, but if somebody's only had a PSA of 4 or 5 and it suddenly goes up to 20, then obviously that would trigger a treatment. And we can do, in terms of imaging, what we can do is a bone scan. So what we're looking for is just checking that people don't have disease that's spread. If somebody's got a fairly high PSA and they're fairly elderly, then it's worth just doing a bone scan to make sure that they don't have disease that's spread. And then sometimes we can just carry on watching them and again defer hormonal therapy for a longer time because, again, there are many potential side effects to hormonal therapy. And if you're 85, you really don't want to be tired and fatigued all day and having hot flushes if you can possibly avoid it. So if there is progression, then patients are generally offered hormonal therapy, and that will be for disease control rather than cure. So why defer treatment? Why put people on surveillance? Why not just treat everybody? Well, obviously, any kind of treatment that you have for prostate cancer, and obviously anybody here that has prostate cancer that's had any treatment will know that absolutely anything we do for prostate cancer has potential side effects. And treatment effects can be anything like, urinary frequency, urgency, incontinence, sexual dysfunction, so inability to get erections, and loss of libido on hormonal treatment, bowel problems with radiotherapy, including frequency and diarrhea and bleeding, hematuria, that's blood in the urine that can happen, and obviously pain and infection are always potential side effects of radiotherapy or surgery. So we don't want to give people unnecessary side effects if they don't need it. But the advantages of surveillance, so the advantages are that obviously you don't require treatment, so no side effects, and no frequent hospital visits either, particularly as we're sort of changing towards doing telephone follow-ups for surveillance patients. And in the future, we're going to be looking at something called supported self-management as well, where the patients themselves can have a larger role in monitoring their own PSA rather than it being all hospital-led. And I'll go on to that shortly because that's quite an interesting development. I mean, obviously, being on surveillance is not going to affect your everyday life. You can carry on as normal, whereas, if you've had radiotherapy or surgery, it's going to interrupt your lifestyle. You're going to have to have periods of rest. You're going to have periods where you're, having treatment and so on. And regular monitoring means that if the cancer does progress, then obviously you can go on and have potentially curative treatment. So the idea is we keep a close eye on things. And then if there is any progression on the future, then it means that you can still have treatment that is potentially curative, that we haven't missed the boat. There are some potential disadvantages. I think one of the biggest ones that we come across is about anxiety, and people being told that they have cancer in the prostate, but it's not being treated. So it is a concern and a worry. And obviously, we do recognise that. There's a worry that it might progress, or that patients might slip through the net. They might miss their appointments or whatever, and might not get seen for a while. And then what's going to happen to the cancer? There's a possibility that disease progression can be missed even with a clinical follow-up. I think the risk of that is low because we do regular PSA checks, we do regular scans. There have been a couple of occasions where disease progression's been missed, but they are very, very rare. Monitoring is mostly done in secondary care, that's in hospitals. So again, that's using up clinic slots for men with low-grade disease. Now that's changing over again because we're doing a lot of the surveillance now with nurse-led clinics. So it's not taking up a doctor's appointment slot, and we're doing it over the telephone. So we're not spending time in clinics. We're not bringing people all the way in from Littlehampton or wherever into Worthing just to say to them, your PSA is stable, we'll see you in 6 months, because that's not a good use of anybody's time. More biopsies. So as I mentioned earlier, if we do trust biopsies to start with, then we will do template biopsies, and it might be that we do further biopsies a couple of years down the line as well. So it means that people that are on active surveillance will need prostate biopsies probably every couple of years or so. And obviously, as anyone who's had prostate biopsies will know, that's not a particularly pleasant experience. And one of the other things that people do get concerned about, and as obviously a genuine potential concern, is that your general health can change. You know, as we're getting older, our health is not so good, and people might develop diabetes or heart disease or have a stroke or get Parkinson's or dementia or whatever. And then that means that you won't be eligible for radical treatment if you're not physically fit enough. So one of the things that we do try to balance is that if people are on surveillance, we want to kind of make sure that they're fit enough that if they do need radical treatment, then we can offer that to them in the future. So on the Sussex, the Western Sussex side of things, we are doing nurse-led clinics for men on surveillance. That is working quite well. It's done by the telephone, and we've had no problems with that so far. We've been running that for about a year, I think now. So that reduces appointment slot times. It reduces the need for patients to travel to clinics and spending ages finding a parking space and petrol or, you know, bus fares or whatever it might be. There is there's always a risk of people not turning up to appointments as well. Whereas if we phone them, we can normally get people, particularly if people have got mobile phones as well. But some people prefer face-to-face contact or contact with the doctor rather than a nurse. So a nurse-led phone appointment isn't suitable for everybody. But for the majority of the time, people are quite happy to have a telephone call, particularly if things are stable. Obviously, if there's any concerns or if there's any disease progression, then we bring people back into a clinic with one of the urology doctors, and they can have a consultation with them. But while things are stable, most people are quite happy to have nurse-led follow-up over the phone. Now, I briefly mentioned earlier that one of the things that's coming in, and it's coming in nationwide, is something called stratified self-management, and that's where we can get the patients to take a bit more of a role in looking after your own follow-up. So it's a nationwide initiative to allow patients and users to coordinate their own care and follow up in collaboration with healthcare professionals to provide a more personalised and individualised package of care. So in terms of men with prostate cancer, there's a couple of ways we can do that. One, men that have completed treatment and had radical treatment such as radiotherapy and prostatectomy or surveillance. So this is men that are sort of generally stable, and we would normally discharge for the GPs to monitor. Is that you can actually go on and monitor your own follow-up. So you can monitor your own PSA results. It will all be on an app. There's an online app called Patients Know Best, where you can have quite a lot of information on there. You can have your PSA results, you can have your clinic letters, you can have all sorts of things. Now, obviously, the hospital will still be following you up as well in terms of keeping an eye on your PSA results and things. We wouldn't expect you to be monitoring your PSA and knowing exactly when you need to be referred back or anything like that. So there will be sort of PSA tracking from our side as well. But it would be more that any follow-up would be patient-led rather than hospital-led. So we wouldn't make regular hospital follow-up appointments. It would be more like, you know, when you're at home, when you need to see the GP. You know, if you've got a problem, you contact the GP. It would be like that. That if you have an issue or a concern, then you would contact us. And then you would monitor your PSA. You can get all your PSA results, but we would be in the background monitoring your PSA results as well, because obviously, you know, there might be occasions when you know, you're not able to monitor your results, or, you know, if your PSA is rising, you might not, you know, understand why that is, or whether it's you know, serious or not, or whether we can just carry on with sort of ongoing post-treatment or active surveillance. And just like a GP appointment system, you would have appointments as needed. You would request an appointment rather than us sort of regularly scheduling appointments. That's just a sort of very quick little guide to how it would work. I'm not going to go through the whole thing. It's a bit involved, but basically the way we want to run it, and it's still in the process of being set up at the moment, but the way we would run it is that we would identify patients that would be eligible for supported self-management. Before they're discharged, would have a training session with them, which might be a group session or an individual session, where we'd say, you know, this is what you should be looking out for, this is how to monitor your PSA, this is who to contact if you have any problems, and so on. So they have a sort of education session. And then we discharge them to self-monitoring. We obviously inform the GPs of that, and then the nursing staff here in the hospital will sort of co-manage that follow-up as well, and specifically in terms of the PSA monitoring. When that's going to come in, we're not quite sure yet. That's all still in discussions, but that is on the cards to do. And it's not something that will be suitable for everybody. It's not that something that everybody will want necessarily to do, but for those people that are sort of interested and motivated to follow and track their own PSA monitoring, I think it's a good idea. And it gives you a bit more responsibility for looking after your own health and follow up, and it eases the burden of work on the on our side a little as well. That's all I've got to say for this presentation. I'm now going to open the floor to any questions. Oh, by the way, are you in, Maddie, or not? All right, my colleague Maddie, I think, has joined as well, and she's Maddie O'Reilly is one of our new urology cancer nurses. She just started working with us a few weeks ago, so I've just invited her along as well. So does anybody have any questions?
Can I just say, if someone wants to ask a question and doesn't want to be videoed, I suggest that you turn your video off first, and then you wouldn't be recorded.
Okay.
At the moment, I've got 4 people at the top of the screen, which looks will be recorded. I haven't got Andrew's face. Andrew, I don't know, are you going to turn your video back on so people can see you?
Yeah, I am. Yeah, hi.
Hi.
And you'll need to unmute yourself. So I will stay on this screen. Brian, you will have to hold it.
Okay. Right. Who would questions, please? Does anybody have any questions? Yes. Robin Weldon. You unmute yourself, Robin. Hello.
All right. Good afternoon, ladies. I'm 81. I was diagnosed with PC 3 years ago, and I opted not to have any radical treatment.
Yes.
The oncologist wanted me to have it, but my urologist didn't. So there was a confliction of views. Anyhow, I am still alive and managing okay. But my question is, should I have an MRI scan regularly? I haven't had one for 3 years.
No. So for gentlemen of your age, the surveillance that we do, as I mentioned in the presentation, is watchful waiting, and that's generally just PSA surveillance. We generally do regular MRI scans for people that are going to go on to have radical curative treatment, such as radical radiotherapy. If that's not something that is on the cards for you to have, then what we tend to do is PSA surveillance. There's no particular advantage to doing regular MRI scans. If the treatment option that's going to be available to you is largely going to be hormonal therapy, if the PSA rises significantly.
Okay, thank you. My second question is, if I'm allowed 2 questions.
Yes, carry on.
The urologist would like to do a TURPS operation sometime.
Okay.
And would that harm my prostate cancer at all, or is that quite safe?
No. So that's a separate operation, and it's done to improve your urinary symptoms. It's not a cancer operation. Obviously, what they do if they do a TURP operation is they sort of scrape away a bit of the prostate from inside your urethra, your water pipe, and they take little chippings away. Those chippings do get sent off to a laboratory. And they get looked at under the microscope. Now, if they find on those chippings that you've got, say, very, very high grade cancer in there, then obviously they'll talk to you about treatment. But otherwise, no, I mean, it shouldn't make any difference at all.
Okay, thank you.
Dave, you got a question?
Yes, interested in this stratified self-management.
Yeah.
In terms, I'm on active surveillance. How would you do your own PSA monitoring? Because obviously it still involves going to a medical place, and I'm still having to go to hospital rather than the GP to go and get a blood test done.
Yeah. So how it would work, the plan is that there would be an app like on your phone, your mobile phone, for example, that would have all that information. So that would have all your PSA results, so you can monitor it either on a home computer or on a smartphone. Obviously, you will still have to go into your GP surgery or to the hospital to have blood tests, but that would be kind of led by you. So the idea is that, you know, rather than us prompting you to have a PSA test every 6 months, you follow that up yourself. You know, there'll be like a little reminder thing on your phone to say, oh, it's time for you to have a blood test. You toddle off and have your blood test, and then you get your result on your phone or on your computer. And then if it's all stable, obviously we just kind of carry on. The nurses in the hospital will still be looking at everybody's PSA results as well. So it won't be entirely down to you to sort of know what to do when you get the PSA result, because it's you know, it's sometimes quite, you know, sometimes it's quite obvious that obviously the PSA has, you know, doubled since the last time. Then obviously you're going to contact us and tell us and let us know. But if it's gone up from 5 to 6 or something, you know, does that, you know, what does that mean? So that's kind of why it's still down to us to kind of monitor the PSA, even though you've got the results there, and we're still be in the background keeping an eye on the PSA as well. So it's a double check. Okay. But I don't know when that's going to be coming in.
And will we be able to have a copy of these notes? Will that be included, do you know, in the recording of your notes?
The slideshows have been recorded. The slideshows have been recorded.
Okay.
Yeah. I mean, I can always send across a copy of the slideshow. That's fine.
Yeah.
No, it'll be a video file.
Okay, thank you.
Can I ask a question now?
Steve
Cheney?
Hello.
Hi.
You got a question, Steve?
Yeah, hopefully. That's assuming Dave's finished.
Yes, I have. Thank you. Yes.
Can I ask you now, Andrew? Moving on from someone who's recently had a radical prostatectomy, moving on to the self-surveillance that you made reference to, is there a considered acceptable limit for what PSA should get to, if any at all, after a radical prostatectomy that would actually trigger a further consultation? I mean, I've got my first consultation. I mean, I'm not from. I picked up this invitation. I'm actually not from your area. I'm actually from the area. But nevertheless, is there what's considered an acceptable a level of PSA before the alarm bells will start to ring, and I will be called back in hospital again if I'm doing self-assessments?
Yeah, that's a really good question. And for people that have had a prostatectomy, theoretically, your PSA should be 0 or very, very close to it, because we've removed the prostate. So there shouldn't be anything in the body left producing PSA. Having said that, some people's PSA is detectable even after surgery, but it would be very, very low at sort of 0.01 or 0.02 or something like that. Now, there's a lot of considerable debate as to what the PSA level should be to trigger additional investigations or treatment. The difficulty is that when the PSA is very, very low, but detectable, then obviously there's a suspicion that there's been a recurrence. For example, if the PSA goes up to something like 0.2 or 0.1, the difficulty is actually seeing and detecting whether there has actually been a recurrence on a scan. Because if the PSA goes up to 0.2, you think, well, actually, your PSA shouldn't be 0.2 because you haven't got a prostate anymore, so there shouldn't be anything there. But if we do a scan, if we do an MRI scan or a CT scan or a PET scan, with a PSA being that low, it's very, very difficult to see whether there has been a recurrence. Now, there's a new type of PET scan called a PSMA PET scan, which may possibly be able to detect a recurrence of cancer with a PSA of around about 0.1 or 0.2. But they're very few and far between, these scanners. I think there's 1 or 2 up in London that we can potentially use. So the difficulty is kind of a saying, well, yes, strictly speaking, if your PSA goes up to 0.2, that would most certainly trigger us, doing more investigations to see whether there's a recurrence. The difficulty is actually whether we can find a recurrence if the PSA does go up to that sort of level.
Yeah, thank you. I appreciate that. So yeah, so really, I should be hopefully at least in my next scan, which would be 2 months after the operation, I should hopefully be expecting a very low sort of nil readings.
Yeah, we would assume that with your prostate removed, your PSA should either be undetectable or very, very low, 0.01, 0.02, something like that.
Okay, thank you, Andrew.
Okay.
Andrew, I've got a question or two.
Yeah.
The Zoladex. How long would you after stopping Zoladex, which I stopped in May? How long would you think before the side effects wear off, such as the hot sweats,
hot flushes and things? So it's entirely dependent on whether your testosterone levels have recovered. So the Zoladex injections suppress testosterone. Yep. And while you're on the Zoladex or Prostap injections, your testosterone levels are down below 1, normally about 0.5, 0.6. And when you stop the injections, what happens is your testosterone levels will slowly recover over time. The rate at which that happens varies from person to person. So somebody can come off hormones and 2 or 3 months later their testosterone is back up into the normal level at about 10 or 11. And then sometimes somebody it's a year, or somebody it's 2 years, and some people, unfortunately, their testosterone never recovers naturally. So it varies from person to person, but the marker is when your testosterone levels come back into the normal range, you should then have those hormonal effects subsiding, because it's the suppression of the testosterone that's causing all of those side effects. Now, interestingly, sometimes we do see men whose testosterone has come back into the normal range at 9, 10, 11, but they still say they're getting the occasional hot flush, or still feeling a bit of fatigue, or one of these hormonal symptoms, but it does tend to go away eventually. What should happen is that as your testosterone level starts to come out of that very, very low range, what we rather unkindly call the castrate range, to sort of 2 or 3, say, which is still below the normal level, but not in that very low range, then the things like the hot flushes can tend to reduce a bit, but things won't go back towards something resembling normal until the testosterone levels recover back into the sort of normal range. And that's so the things like hot flushes, tiredness, mood swings, erectile dysfunction. Although obviously if you've had radiotherapy or anything like that, your erectile function is going to be affected because of that as well. Low libido, these sort of things should recover once the testosterone levels recover, but that can take, that's very, very variable how long that takes.
Yeah, mine is I was in the castrate level down at 0.2 a month or so ago, and I stopped it in May. Is there anything I can do to try to improve testosterone levels, or
no?
Is there anything can be done, or is it just something I've got to live with?
No, unfortunately, it's something you've just got to wait and see if it improves. We certainly don't advocate using testosterone replacement, for example, which some people do, because if there's any residual cancer lying around, then if we suddenly surge your body with testosterone by giving testosterone replacements and injections and patches and things you can get, that can trigger the recovery of any remaining cancer cells that might possibly be around. So we certainly don't advocate testosterone replacement. And there's nothing that I'm aware of in terms of diet or anything like that can improve. It really is just a case of waiting to see whether your body sort of kicks back into gear, so to speak, and starts producing testosterone naturally again. The general thing about whether testosterone levels recover fully or not is usually linked to how long you've been on the hormones. So if you've been on the hormones for 6 months, then you're going to recover fairly quickly. If you've been on the hormones for a year or 2 years or 3 years, obviously your recovery might be more prolonged. And like I say, in a small number of men, maybe 5 to 10% of men, the testosterone never recovers, unfortunately, and you end up living with hormonal symptoms permanently.
Okay, thank you on that one. And the other question was PSMA scans.
Yeah.
Now, it was only because I was able to get a PSMA scan that the cancer was the secondary cancer, which was in the lymph nodes, pelvic lymph nodes, the cancer was found. So when are NICE going to approve PSMA scans?
I don't know. I don't know whether it's already been approved by NICE. The difficulty is there just aren't that many scanners around. There are some PET scanners that might be able to be adapted to use PSMA, but that will require a significant change in upgrade in the infrastructure, I'm afraid. But PSMA is in use. It's just the places that are available to do it are very, very few and far between at the moment, which is a shame, because we're talking about it all the time in conferences, and it's got a much greater sensitivity and a much greater specificity than standard PET scanning, and certainly than multiparametric MRI scans, particularly in terms of detecting recurrence, particularly in terms of detecting micrometastatic disease, particularly in terms of detecting lymph node involvement. It's very difficult when you've got a lymph node that is, you can see on a CT scan that it's only marginally enlarged. We don't know whether that's significant or not. But on a PET scan or a choline PET scan or a PSMA PET scan, you might be able to see that there's sort of uptake in those areas. But it's, as far as I know, it's been approved for use. It's just that it's just not widespread because we don't have the infrastructure, we don't have the machines to do it. Like I say, although there are some, I think, that can be converted from doing normal FDG or choline PET scans to doing PSMA PETs.
Okay, thank you. Are there any other questions from Mike? Mike?
Yeah, I'm interested in this testosterone testing because I was treated eight years ago.
Yeah.
And I've never had a testosterone test, and I don't think it's ever come back. So,
okay.
T8, it doesn't really matter, but
yeah. So I mean, what we do in at our end, we're largely doing nurse-led post-treatment clinics. So for men that have had radical treatment and have been on hormones, so obviously if you had, say, radical radiotherapy, then as well as monitoring the PSA, every 6 or 12 months, then we are monitoring testosterone levels after people come off hormonal therapy until the testosterone levels recover back into the normal range. So, because it's obviously important to monitor that from our point of view, because we need to know, whether people are still having ongoing hormonal symptoms or not.
Yeah, so 8 years ago they didn't do it. So this is something new, is it? Because
yeah. I think we've probably been regularly monitoring testosterone for a few years, but maybe not 8 years ago, but I think because we're now concerned more about, there's been an awful lot of stuff about living with cancer and living with the long-term effects of cancer, and so we do want to know, what people's quality of life is, after having had cancer treatment and having had, potentially curative treatment, how people are, living, months and years down the line with potential ongoing and long-term side effects of treatment. So that's something that we've been, looking at and monitoring more closely in recent years, certainly.
Okay. Could I just ask another one? With the active surveillance, and you've mentioned low grade. So what, for instance, is the PSA level for low grade definition, and also the Gleason? What's that definition?
Yeah, that's a good point. I didn't really define it, did I? So generally speaking, for men that are on active surveillance, there's Gleason 6, 3+3 prostate cancer. Very occasionally, we do surveillance on men that have got Gleason 7, which is 3+4 7 rather than 4+3 7, but only if there's just a kind of a little bit, like 1 or 2 cores from a template biopsy of sort of 20 or 30 samples, and we're fairly confident that even though it might be Gleason 7, that there's only a very, very, very small focus. But generally speaking, most Gleason 6s will be eligible to go on surveillance unless there's a lot of it. If we take 14 cores and 12 out of the 14 calls are positive. Even if they're Gleason 6, if they've got a lot of it, then we would probably steer people more towards treatment than surveillance. But generally speaking, what we call low-grade, low-volume disease, so that's generally speaking Gleason 6, and you know, a minority of positive biopsy cause, and a PSA generally speaking of less than 10.
Okay, so that's quite a high number, isn't it? So
yeah,
to have. Okay, it's just that I'm aware of somebody who's on active surveillance with low grade, and his PSA started at something like 7.
Yeah.
And then it went up to 9 or 10, and then it dropped back down again.
Yeah, can do.
Is there any explanation for why that might happen?
No. So we don't know. So no, it's a funny thing. The PSA, we know the PSA fluctuates, and we know there are occasionally specific reasons why this PSA might go up if you've got an infection or inflammation, prostatitis, if you've had any sort of damage or injury. Some people say people that cycle a lot might put the PSA up a little bit because of the pressure on the sort of that side of things on a saddle. I'm not sure if there's a lot of evidence to suggest that, but we do see sometimes somebody's PSA, we are quite often on surveillance, somebody's PSA might be bimbling along at 5 or 6, and then suddenly it jumps up to 9, and then 3 months later it's gone back down to 6 again. Why that happens, I have no idea.
Okay.
But that's not uncommon.
Right. Okay. Dave.
Hi, Brian. Just to comment, I had a similar experience. I was initially, when I was picked up by Picasso 2 years ago, 4.7. And then at the beginning of this year, about February, I had a blood test and it was 11.5, I think.
Right.
And the subsequent, I had another MRI and the subsequent blood test, my latest one, which was done in October, it come down to 6.
Yeah.
6.57, I think it is.
Yeah.
And memory. The only thing I can put it down to, and then, you know, a lot of people will concur with other diseases with this, is I retired at the beginning of the year. I sold my business and I had a lot of hassle sorting out accounts.
Yeah.
I was under a lot of stress at that time.
Yeah.
And I think stress, that's the only thing I can put it down to. Not a clinical answer, I know, but
no, I agree, and I think we underestimate the power of stress sometimes to cause significant changes in the balance of our, you know, hormones and various other things that go around in our circulation. I think stress is a very important factor, and yeah, I mean it may be. Stress releases a lot of hormones. It releases certain proteins and enzymes into the systems, and that, you know, and everything interacts with everything else in the body. And I'm sure that you know, these things like increased cortisol levels and C-reactive protein and things like this probably have a part to play. It's not proven, but that's my hunch as well, actually.
Robin?
Yeah, when should we get worried about our PSA? Mine went up to 20 a year ago, and I was put on a deuteride, and it's come down to 13, and it seems to stabilize between 13 and 14.
Yes.
So what should I look for?
The answer is a significant rise in the PSA. So the actual PSA value itself isn't a particularly good indicator. So you know we've been talking about these varying PSA levels, and somebody might be quite stable with a PSA of 4, somebody might be very stable with a PSA of 15. So the actual level of PSA isn't a huge concern unless it goes up significantly to 40 or 50 or 100 or whatever. But while you've got a PSA of around 13 or 14, the important thing is it stable? So the thing that we get concerned about isn't the actual value of the PSA itself, unless the PSA is extremely high. What we get concerned about is the PSA rising, and how fast is it rising? So what we talk about is things like PSA velocity and PSA doubling times. So if the PSA goes up, for example, if you have a PSA of 5 and it's been going along at 5, and then the next time you do it, suddenly it's 10. So that your PSA has now doubled from 5 to 10. What's so important is how long that takes as well. So if that PSA is doubled between one blood test and the next in 3 months, so obviously your doubling time is 3 months. And we get concerned if people's PSA goes up, sort of doubles, and particularly if it doubles in less than 6 months, that usually is a cause for alarm. Sometimes the PSA goes up, but it might go 5, 6, 7, 8, 9 over the period of 3 or 4 years. That's fine. What we don't want is it to go from 6 to 11 in the space of 3 months or so.
Okay, that was helpful. Thank you.
Okay.
Does anybody else have any questions for Andrew? No, nobody's shaking their heads.
Good, thank you. That's timed it well as well, because I had an hour as well, actually, so that's very, very good.
Thank you,
Andrew. That was a wonderful presentation. Thank you
very much. Thank you very much. It's always a pleasure to do these.
We obviously like to see you in real life.
Yes.
When you come along to us.
Yeah.
And you usually you see a lot more people, but despite the fact that we've got a 91-year-old in our audience today, quite a number of our members do feel that they're too old to do Zoom. But
there's no age barrier to technology.
No, but we've got to get that over to our other 60 members, because what you're offering us is absolutely really positive, good information, and what we're trying to get around to everyone. So thank you very much for coming along.
Okay. Yeah, thank you for listening.
We'll be in touch later in the year when we will be able to see you in real life.
Yeah, hopefully we'll go back to face-to-face meetings. That'll be nice.
Yeah, that's
All
great.
Right. Okay. Thank you very much, everyone. All right.